Well, thank you everyone joining this evening. I am Dr. Perry Maynard with Integrated Health Systems. I see some names on there that are familiar and some new names. Welcome everyone. Tonight, as you can see, the topic is understanding dysautonomia. We have talked on this matter before, but it's been a while, so I wanted to kind of redo this topic because I know a lot of individuals have questions on the topic that is dysautonomia. So today we're kind of this is gonna be an overview. This topic is a very complex topic that, we could spend weeks, days, years chatting about, and we're gonna try to kind of sum up a lot of big points in, hopefully a half an hour, 40 minutes. So my goal is, we'll chat through things for about 30, 40 minutes and then open it up for questions at the end. So if you have questions, please hold them to the end, or you can write them in the chat as I go through, in case you're concerned about forgetting them. And then I can go through and then answer them at the end. But let's definitely try to hold questions for the end, and then I'll definitely make sure we have some time to go through it. So, like I said, Dr. Perry Maynard. So I am a board certified chiropractic neurologist. Some of you may be saying, what is that? I've never heard of that. So, just like in most of healthcare, in medicine or DO, same in chiropractic, there are specialties. So, just like in medicine, where you maybe have a board certified pediatrician or neurologist, doctor of osteopathic, similar thing. In the profession of chiropractic, same thing. And so I have gone through postdoctoral work in clinical neuroscience and received my diplomate in clinical neuroscience. So that's what makes me a board certified chiropractic neurologist. And you may be asking, well, what is the big difference between that and a medical neurologist? Really, the biggest difference is ability to prescribe. So in our clinic, we do have medical providers that do play that role in prescription, but I do not. And then also, it's kind of the way we look at things. So we look at the same thing and we read the same neurology. It's not a different neurology, it's the same neurology, but it's how we approach things. So, in the traditional sense in neurology, everything is pretty black and white. Do you have a stroke? Do you have a tumor? For those of you who have been through that route, you can see there's a lot of times not a lot of clarity. And so we are trained in understanding that same aspect, but what about the patients where they don't fit a traditional medical diagnosis, right? You see this a lot in concussions, right? Concussions are functional injuries a lot of times, right? Imaging is normal. A lot of standard testing is relatively normal, but these individuals are still wildly disabled because it's more of a functional injury. So we do a lot of looking at how is the brain functioning? Yes, it may be grossly normal, like you see a lot of written in a lot of medical reports, but is it really working as well as it should? And how is it working compared to a healthy peer or cohort? And so that's really the biggest difference of how we look at things. And I'll kind of explain the difference in how I look at dysautonomia, a little different than maybe you see traditionally. And all these are going to come from research, but the consensus, as you're aware of, looks at it in a certain way, and I'll kind of tie that in as well. Most of the patients I see are concussion patients, dysautonomia patients, and a lot of inner ear disorders and balance disorders. I see other things as well, but that's a big chunk of the patient population that I see. So let's get started, right? So the term dysautonomia gets tossed out a lot, but what gets tossed out more is POTS, right? Or postural orthostatic tachycardia. And this is kind of like dementia in that a lot of people are like, what's the difference between dementia and Alzheimer's, or dementia and Parkinson's, dementia and Lewy body, different things like that. So just like dysautonomia, people are like, well, okay, there's dysautonomia, there's POTS, there's orthostatic intolerance. Like, is it the same thing? What's the deal with that? Can these terms be used interchangeably? And dysautonomia is just an umbrella term for dysfunction of the autonomic nervous system. Doesn't really tell you what is going on, right? So when we look at things like POT or orthostatic intolerance or IST, inappropriate sinus tachycardia, vasovagal, multiple systems atrophy, pure autonomic failure, right? These different things you can see underneath, those fall underneath the umbrella of dysautonomia. And I think that's important because POTS is very different than IST, and it's very different than multiple systems atrophy, and it's very different than pure autonomic failure, and so on and so forth. So it's really important that we understand the difference, and these things are appropriately diagnosed because I think it changes outcome and it changes possible treatment strategies. So I think that's really important. The most common one that I think individuals are chatting about and that you see a lot is POTS. And what I hope to shed light on a little bit is that I think that term is a little maybe inappropriately. I don't know if that's the best name for the condition a lot of times, right? Because when you look at it, the term postural, so standing, orthostatic, so changing position relative to gravity, so being upright. Tachycardia is true, but a lot of times the tachycardia is a symptom for something greater that is going on. And so the problem is a lot of times treatments and therapies are focused on the heart rate, and everything's focused on the heart rate. And like we'll chat about, a lot of times that is just trying to compensate for other things. And if you can fix or improve or support other systems, sometimes the tachycardia can improve. So I think that's a big piece. So what are the symptoms of autonomic dysfunction? And this is where I think individuals really struggle because of the gamut of symptoms that one can experience. It's not uncommon, and I know some of the names on here, because we've chatted about this, have been through this experience. Most commonly patients with POTS or dysautonomia, they usually have a neurologist, they usually have a cardiologist, they usually have a gastroenterologist, sometimes a rheumatologist, um, and so on and so forth, right? And this is because when you look at the autonomic nervous system, it controls so many different systems of the body. So you can see your symptoms: vertigo, dizziness, chest pain, tremors, anxiety, migraines, upset stomach. So you're thinking, like, this is crazy. We have inner ear symptoms, we have cardiac symptoms, we have psychiatric symptoms, movement symptoms, GI symptoms. And that can be very confusing for a doctor or a healthcare provider who is not well experienced in this arena, because you want to send to all these different specialties, but sometimes it can be coming from failure in one system, and that is the autonomic nervous system. I think I heard this. I don't know if I heard this from another doctor or maybe a patient one time, that had a great analogy. Having autonomic dysfunction is like a bad hangover. That's like the best way to think about it. And when I brought that up to patients, they most of the time agree. They're like, yeah, this is like a bad hangover, right? Because you're dizzy with a hangover, you're anxious, you're shaky, you feel fatigued, you feel weak, you feel nauseous, so it's kind of like being hungover every day. And for those of us who have had that experience, the thought of that is terrifying, so this can be very debilitating for individuals. So as we can see here, dysautonomia can impact the whole body. So it can affect the brain, the mouth, eyes, heart, stomach, gallbladder, and so on and so forth. Even the immune system. There is a huge role that the sympathetic nervous system plays in immune function. So it's really, really important. And you can see this sometimes with individuals with dysautonomia. They develop immune issues, autoimmune issues, and it becomes this vicious circle of chicken of the egg, because then those immune issues then can make the dysautonomia worse. So it's really a multiple system disease process that occurs. So let's chat about what should happen when we stand. So I'm going to chat heavily on autonomics as it relates to things like POTS and the cardiac and the brain aspects of it. But like we mentioned, your autonomic nervous system controls everything from mucus production in your mouth and your eyes, to your ability to sweat, to your ability to urinate, to your ability to have bowel movements, um, sexual function. It plays a role in a lot of different things. We don't have time to chat about all those. And clinically, for my patient population, the most important part is the inability to stand upright, right? Most of my patients are fatigued, they have brain fog, um, they pass out. And so that's where I'm going to really touch on, because that's where I spend the most time clinically. So, what really happens when we stand up? And we kind of take this for granted. So, gravity is constant. We can't really get away from it. We can go into a pool, and that can somewhat change it. And like we'll chat about, pool workouts actually can be a really cool hack for individuals with dysautonomia, but gravity is pretty constant. And so when we are upright, gravity is going to want to pool blood in our feet, right? In our feet, in our gut. And so, as you can see here, right, when we stand, we can see a big drop in blood volume into our thoracic cavity and our lower extremity. And then you can see a 10 to 25% shift of plasma into interstitial tissues. And ultimately, the big thing is there is a decrease of return back to the heart. And this is really what kicks things in. So, this picture to the right I think it's really cool. So you can see here that as atrial blood pressure decreases, so pressure within the heart in different arteries and things like that, this is monitored by what is called a Bear receptor or Bear reflex. And the Bear reflex is a pressure reflex, okay? And this is largely controlled within the brain, largely the brainstem and the hypothalamus, and it's a reflex. And when we measure low blood pressure, ultimately you can see we should decrease parasympathetic outflow and increase sympathetic outflow in order to constrict arteries, increase heart rate, and increase the force of contraction. So when we're ultimately wanting to get blood to our brain, there's this idea of right cardiac output, right? So the output coming out of our heart, and then we need to maintain that. And so you can see here a mix between cardiac output and peripheral resistance help to maintain blood to all of my organs, but most importantly to my brain, right? And so you can see this is a big loop. And when this fails, individuals get faint, they feel foggy, all those symptoms that a lot of individuals with dysautonomia feel. And although we won't get super in detail into it, I really hope to start shifting individuals' minds away from this oversimplistic parasympathetic sympathetic mindset. They are both going at all times, and it is a constant dance and interplay, and they do different things. There is a lot of oversimplified activate parasympathetic and increase sympathetic and vagal stimulation, and it's an oversimplified thing that is not true scientifically or even clinically. They both are needed, and we need them to both work, and they do very much things right. Everyone looks at sympathetic as a bad thing, but in a lot of patients with POTS and dysautonomia, they have a lot of sympathetic failure. And when I say sympathetic failure, the areas of the brain that regulate outflow to tighten arteries does not work very well. So it's not always the bad guy. So I hope that's a big piece I hope to drive home this evening. So let's chat a little bit about diagnostic criteria for POTS. Like I said, we're not going to get heavily into all the forms of dysautonomia. We're just going to talk POTS because this is most common. So as you can see, and it's different for pediatric than it is adults. So I think technically adults is now it's 40 beats per minute. So anywhere heart rate more than 30 to 40 beats per minute within 5 to 30 minutes of standing. We'll chat about some of the testing we do, really looking at like a 10-minute tilt. It can occur with and without changes in systolic or diastolic blood pressure. More often than not, I would say clinically there are shifts in blood pressure. And I can chat where you can have normal blood pressure, but heart rate is increasing, but the blood pressure may artificially look good because it's being maintained by the tachycardia. Because, like we talked about, ultimately, if you're not getting enough volume back to your heart, and so your stroke volume out of your heart is not sufficient, you have reflexes to kick in tachycardia to try to maintain pressure within the arteries. So heart rate does play a role in blood pressure. Blood pressure is not just the tightness of arteries, that is a component, but part of what makes blood pressure, right? So systolic blood pressure is the force of blood from the heart into an artery. So that is how compliant is the artery, but how hard and forceful are we pushing blood in? So there's that. There is some testing looking at standing plasma norepinephrine, so like adrenaline. We don't do a lot of this testing only because it's difficult, but you see it in the research. And then ultimately the big thing is must occur in absence of other conditions, including anemia, hyperthyroidism, prolonged bed rest, dehydration, and medications. This is really important. And I see this with a lot of patients. I had, some this week where similar things where, they look positive for POTS, but they're also borderline anemic or they have thyroid issues. And this is really important because it's a very different outcome. It's a very different treatment, you know, helping to improve someone's anemia by maybe giving them iron if it's an iron deficient anemia, or if it's a megaloblastic anemia, treating that appropriately, whatever it may be, you can sometimes see that be generating POTS-like presentation. And so it's really important that there is a thorough workup that is done, not only autonomic testing, but a bedside test and laboratory testing to look at things that can mimic it, like hyperthyroid, anemia, and so on. So that is very, very important. When you look at the pathophysiology, and this is by no means everything, honestly, this list, a lot could be added to it. This is probably when you look at some of the medical literature, this is what you'll heavily find. But clinically, there can be a lot of things, especially when you get into neurogenic. And when I mean neurogenic, when the brain is being a little funky, there's a lot of different areas where it can come from. But ultimately, most commonly when you're looking at the literature, is neuropathic. So deinnervation to sympathetic nerve fibers in the extremities. So things like small fiber neuropathy. Small fiber neuropathy is a neuropathy against the small nerve fibers in your body. These are the nerve fibers that transmit pain, temperature, so hot, cold, light touch, things like that. But small nerve fibers are also autonomic nerve fibers. So these individuals sometimes you can see with like diabetic neuropathies, small vessel disease, or very commonly post-viral infection. You can see this, and you're seeing a growing body of evidence in some individuals that COVID and other viral infections can create small fiber neuropathy. So the nerves that transmit signals from your autonomics, your parasympathetic and sympathetic, can start to become affected by the immune system. And so then you can start to see autonomic failure, hypovolemia, and blood volume regulation issues, alterations in the renin angiotensin aldosterone cycle. So this is the cycle within the kidneys that help to regulate blood volume. I do see this clinically. It's a very small percentage of what I see. And part of that could be because these things get caught up traditionally. So all these things I'm mentioning to you, I do see clinically, but I tend to see the outliers. I tend to see the ones that don't fit this mold. And so no one really knows what to do. So although occasionally you do see hypovolemia, I don't see that a ton, but that can be a cause. And then, I had a patient recently who's got some dysregulation in the renin-aldosterone cycle, and that could be a big thing, right? And that plays a role in the kidneys and reabsorption of sodium to increase blood volume. You see this sometimes individuals with like Addison's disease. Addison's disease is a adrenal disorder that can cause really low blood pressure, along with other things. And so you can see orthostatic intolerance and POTS-like presentations, but secondary to a true adrenal pathology or disease. Really important to differentiate because once again, the treatment options and the testing and what needs to be done is very different. Central hyperaginergic POTS. This, like we said, central, more brain. These are, once again, this is a little bit less common than I think low blood pressure, high heart rate, but these are individuals where both blood pressure and heart rate skyrocket. So let's just say, for an example, at rest, someone is 120 over 70 and their heart rate is 70 beats per minute. And you tilt them up where they stand and their blood pressure goes to 160 over 100 and their heart rate goes to 120. That is an example of a hyperaginergic POTS in that everything is going crazy. And so this is actually an example where there's too much sympathetic outflow, where we are just getting this huge adrenaline dump. And so you can see this come from neurological issues. So you see this with brain injuries, or what are called autonomic storms, which are common with brain injuries. But you can also see this in things like mast cell activation syndrome, or MCAS, which, like you can see, is the fourth one. This is a pretty hot new topic, and I'd say trendy diagnosis. It's a very real thing, and you see it a lot clinically. I think it's being maybe a little, I don't even know if I want to say overdiagnosed, but I think individuals have a POTS diagnosis and they get mast cell and it ends there. And it says, well, we're just going to treat your mast cell and your POTS. There's nothing else to do for your POTS. And I don't think that is true. And although I have seen the better you can control someone's mast cell, you can make massive improvements in their POTS. I've seen patients go from fainting to not fainting with getting on appropriate treatment for MCAS, whether that be with over-the-counter antihistamines or with pharmaceutical antihistamines, along with other things. I think way more can be done, and usually there's way more to the story than just mast cell. I think that's really important because most patients I have coming in currently come in usually with a mast cell diagnosis, an Ehlers-Danlos diagnosis, and then maybe like a lupus diagnosis, kind of like a triad. And it's like kind of like everyone. And I think that's important, but I think we want to be careful of sometimes that defining individuals because there still can be other things contributing to the dysautonomia. Okay. So when we look at testing, and once again, I may add a little bit that is not on here, you know, it's really important that, like I said, a detailed history. We have to have an idea of what might have set this off. Is it post a head injury? Is it post a viral infection? Is it medication induced? Is it stress? Was there a death in the, there can be so many different things that can lead to autonomic failure. So a really thorough clinical history is key. Next is examination. So a standard bedside examination, neurological examination. Our examination process is about 3 hours long. I'd like to know the last time you went to, your PCP, to Kaiser Centura, nothing against those, and you were there for 3 hours getting worked up. Probably never, right? So in fairness to them, 15 minutes is not enough to get a thorough eval. 30 minutes is not enough time to get a thorough eval, right? We need time so that we can do a really comprehensive physical neurological examination. When we look at laboratory testing as it relates to dysautonomia, remember we talked about looking for anemias, looking for signs of autoimmune diseases, thyroid conditions, hormone conditions, right? We want to screen for a whole host of other medical conditions. I put on here mast cell markers. I don't tend to run those clinically because I don't think they're very accurate, but they are in some of the recommendations when you look at like Dysautonomia International, and then things like plasma and norepinephrine. Once again, we don't run that clinically. It's just kind of hard to do. And then the big thing is autonomic testing. So, it's not uncommon for individuals to just go to even to their cardiologist and just sit on a table, get a heart rate monitor put on, stand up, and get the POTS diagnosis. But really, we need a thorough eval. And there's not a lot of people who do traditional tilt table testing or do really good thorough autonomic testing. And so what does that look like? So a really good battery of autonomic testing, or what we perform, is a handful of tests. So we do testing where we're looking at continuous blood pressure, continuous heart rate, respiration, and oxygen. Now, there's some cool stuff and some cool individuals that are measuring constant cerebral blood flow velocity with transcranial Doppler, which is really cool. We do not do that currently. I'm hoping in the future that we do, but there are some other individuals who are doing that, and I think that's a really cool addition. You see that in the research, but you don't see that a ton clinically. But so we have these continuous vital readings, and the first test is 3 minutes at rest, and we just want to look at all these different things. So ECG, heart rate, rhythm, all those different things, oxygen, blood pressure. And then we do what's called a deep breathing test. And a deep breathing test looks at what is called cardiovagal function. So how well can I slow down and increase my heart rate with my breath? Okay. So ultimately, when I breathe in, the stretch from my lungs sends a signal via a nerve to my brain. It puts the brake on my cardiovagal system, or part of the vagus nerve, or the vagal system in the brain, right? So vagus nerve, but you have nuclei in the brain, so that's different than a nerve. And it says, how well can I put the brake on that, which then causes my heart rate to start to rise. So if we think about it, the cardiovagal system is putting like a constant brake on the heart rate. And if that doesn't work, sometimes the heart rate starts to rise. And so this is why individuals who are very metabolically fit, part of it is their cardiorespiratory system is good, but part of it's neurogenic, and neurologically their autonomic system is fine-tuned. And so when you breathe in, right, your heart rate should increase, and when you breathe out, it should decrease. When we're younger, it should be a greater spectrum. So we look at what's called an EI ratio, expiratory to inspiratory ratio. So like if my resting heart rate is 60 and I breathe in and it goes to 80, and then when I breathe out, it goes down to 45, and so on and so forth. That's a really big gap. And that is a sign of really healthy cardiovagal function. And that's really important because when that doesn't work, we start to get concerned of things like autonomic neuropathies, right? Or different things. It's an autonomic reflex, and we just want to see, does that work? Because if that doesn't work, that helps to clue us in on other things that may be going on. And then we look at what is called a Valsalva test. A Valsalva test is a test to measure baroreceptor reflex. So what individuals do is they're lying down and they blow into a tube. For those of you who have been in our clinic and had this testing, you won't forget this. It's pretty difficult to do, but you blow into a tube at a certain pressure and you hold it for about 15 to 20 seconds. It's pretty hard. And the idea with that is that by increasing intra-abdominal pressure, we create a decrease in blood flow back into the heart. So we are causing a decrease in stroke volume transiently and cardiac output. And we're seeing how well can their brain and their baroreflex detect that and cause their blood pressure to go up. So what should happen is that you blow into the tube, blood pressure goes up, and then it drops precipitously, and you see heart rate raise to compensate, and then ultimately blood pressure should reach baseline, and then it should overshoot. So there's 4 phases to a Valsalva: phase 1, 2, 3, and 4. In the 4, we should see blood pressure rebound. So if blood pressure starts at 120/70, I want to see that it reaches at least 120/70. If anything, I want to see it overshoot. And that lets me know that that baroreflex works. In some individuals, their blood pressure plummets and it takes forever to come back. And then you're getting concerned, why does that baroreflex not work? And then what we want to look at next is a tilt table test. And a tilt table test is cool because it does the same thing that the baroreflex does, but it's more complex, right? So ultimately, both of these things are just decreasing blood flow back to the heart. So when I tilt someone up, gravity is pooling blood in their feet and in their abdominal cavity and their organs. And so that should offload the baroreceptor, and they should be able to detect pressure changes. And I want to see, can they maintain blood pressure, heart rate, respiration, and ultimately, really the big thing we care about is, do they maintain cerebral blood flow? And this is a hard thing, and this is why transcranial Doppler is really cool, in that that gives a really good picture into what's actually happening to cerebral blood flow. Ultimately, and we won't get into it because this could be a separate discussion, cerebral blood flow is very different than how we regulate blood flow in the rest of the body. That being said, if the autonomics in the body, i.e., my ability to maintain blood pressure in the periphery, fails, my central system will fail as well. Or it will have to work extra hard to try to compensate, and that's not good. And so the one downside to all traditional autonomic testing is it does not give you a direct picture into cerebral blood flow. It gives you an indirect picture. Now, if someone passes out, it's quite clear they lost blood flow to their brain. But in a lot of subclinical cases where it's just a little lightheaded, a little headache, it doesn't quite confirm that. Usually you're correct and you can assume that, but that's where I think transcranial Doppler is a cool new thing coming up in this world that hopefully more and more providers will be able to have to add answers in. And so the tilt table test, right, and that's really important because we compare that with the Valsalva, because they're both looking at how you can regulate blood pressure, because some people will have a normal Valsalva, but an abnormal tilt, right? And that's very different than someone where they're both not working. And you see this a lot of times in brain injuries or neurogenic causes. And then there's a few other tests for those of you who have been in our office: a hand grip test, a cold pressor test, and things like that. These are some other tests to look at blood pressure, but I won't go into them too much because I know I'm chatting a lot on testing. This is a really cool picture. So going back to that comment I made about, actually, maybe I will bring in the cold pressor and hand pressor because I think this helps a ton. I'm going to try to break this down. I know this is crazy complex for most individuals, but this is looking at the brain stem. So the low part of the brain, like the most primitive part of the brain, closest to our spinal cord. This is like the autonomic reflex. Okay. This is it drawn out. And so let's look at some things. So in green is the output. So that's the RVLM, or the rostral ventral lateral medulla. IML is my sympathetic. So RVLM, IML is my sympathetic. So remember, it's the output to tighten my arteries to get blood to my head. Okay. And as we look here, we can see my baroreflex pathway is in orange. And that consists, you can see, of NTS in what is called the reticular formation. And so that NTS is also that system that is associated with cardiovagal function, right? So it does many different things. And you can see it integrates very heavily with that RVLM. And so here's that basic reflex you can see. But then what's really cool is see how you see in red and in blue other pathways that integrate. So your vestibulosympathetic pathway, which is in essence your inner ear. So your inner ear plays a huge role in blood pressure regulation, because if you think about it, when you go from lying to standing, your inner ear is the quickest thing to tell you that you've changed position. So it is not uncommon in brain injuries or in inner ear disorders that they develop dysautonomia. This is also why I do a lot of vestibular rehab in patients with POTS, and it can sometimes help significantly in managing their symptoms and improving quality of life. But as you can see, there's other areas that play a role as well. So this top circle up here is part of our cerebellum. So our cerebellum is our coordination part of the brain. It coordinates movement, mood, a lot of different things. So our cerebellum plays a huge role in autonomic control, but then even more so is our limbic system and our hypothalamus. So like I talked about, if we think about our emotional brain, that makes sense because if I'm running away from a lion, I need to change blood pressure. I need to change heart rate. And so you see this in patients where their anxiety perpetuates their POTS really badly. Dysregulated sleep, trauma, depression, right? All these different mood disorders can have an effect on POTS and vice versa. They can kind of feed off each other. Or it's crazy. You can see this where arousal can affect people's POTS. So I've seen this with good arousal or bad arousal. So, individuals, in intercourse, in fainting. So you see these limbic, or they get really excited or they get really sad about something. And that limbic system has a heavy influence on these autonomic controls. And so the reason that's important is you can see when we're looking at a patient, it's not just salt and compression. It is, what is your sleep? What is your mood? Are you anxious? What does cognitive function look like? What does your inner ear look like? What does balance look like? What do all these systems that control these basic autonomic reflexes look like? And this is where you get into some of the, where I think treatment can be a little bit more tailored towards the individual. In some individuals, cognitive behavioral therapy may be super helpful. In other ones, vestibular rehab may be really helpful. In other individuals, maybe it's immunotherapy, but it's understanding this whole big picture. And that's why I love this picture. I know it's confusing for most, but the point of it is to just show that there's so many levels of the brain that help to regulate blood pressure and heart rate. And if an individual has POTS and dysautonomia and these things are not being considered, I think injustice is being done. And an individual really needs to be looked at thoroughly. Everything from, do the nerves in the body that regulate blood pressure and heart rate work, yes or no? Is there a sign of a small fiber neuropathy? Is there a spinal cord injury? Is there a sign of an autoimmune disorder? But then how is the brain regulating it? And that's why all the testing is really important, because all that testing I just mentioned, on top of thorough neurological evaluation, that's where some people are like, why are you doing vestibular and balance testing, and vision testing on POTS patients? It's like, this is why I do vestibular testing, vision test, like the same testing I do on my concussion patients, I do on POTS patients, because it's the same circuitry that gets affected. And so that's why we're very thorough in our eval. And then we compare that with autonomic testing to try to get as close as we can to figuring out what are the areas that are affected, so we can figure out what therapies may be ideal to help support them on top of maybe other treatments or medications that they are using currently. I'm going to skip past this, but this is kind of the concept where I chatted about how vision inner ear and cervical spine play a huge role in autonomic control. And ultimately, I'm going to wrap it up and we will leave it for questions, right? It's really important that if you're going to a provider, there is a comprehensive health history. There is laboratory work, physical, neurological examination, orthopedic evaluation, right? Looking at hypermobility. And then my personal opinion is vestibular testing, balance testing, cognitive testing. If you are going somewhere and someone is spending 15 minutes with you and just puts a pulse ox on and sit to stand, gives you a diagnosis and gives you treatment, sends you on your way, I'm going to make the argument that I think we can do better, and we can do better than that as healthcare providers in society. But we have to understand that currently the standard of care, compression garments, it is a whole host of medications. So midodrine to cause vasoconstriction or tightness in blood vessel, fludrocortisone, which is kind of acts as like a fluid retention. So it causes increases of fluid to increase blood pressure, different medications to slow heart rate. There's some newer medications that work on acetylcholine because acetylcholine is the main neurotransmitter in the periphery that works on the autonomic nervous system. So there's some newer dopamine medications. And from my experience personally, these can help some individuals, but most individuals, at least I see, still really struggle. And it's because, like I said, the autonomic nervous system is complex and it's going to be very hard to create a monotherapy or one therapy to fix them all. If you look at POTS literature, you see a bunch of different opinions. And you see some people say it's caused by this and it's caused by that and it's caused by this. And you dive into some of the big researchers and you see influence of so many other different systems. It's kind of like, when you look at Alzheimer's, I don't think we will ever find one drug that solves the problem. It's the human body and we are complex. And to think that one drug or one treatment or one protocol or modality will fix every person, I don't think, unfortunately, is true. We need a tailored approach that is specific to that individual and that individual's physiology, or that's how we work. And like I said, I think that is a better approach, but I don't think that medications are a bad thing either. I think they can work in unison. Medications with physical rehabilitation, some of these approaches to give the most comprehensive approach for patients, I think is ideal. So big things I want to leave you with is act sooner rather than later. It's never too late. There's really great providers all around the country. We do consult with people around the country. We treat a lot of people from around the country, but sometimes people call from other states, and sometimes I can put them in touch with a provider who does similar work in that area. And so that's why we do offer free consultations to just kind of get familiar with the care and see if we can find you a provider in your area, or if we think we would be a good fit and there's something we can do to help you, or just kind of help guide you. And really, I do that so that we can see what a good step is, because a lot of individuals with dysautonomia are very lost and they've spent a lot of money. And so that's why we do the free consults, to try to say, hey, let's take a look and let's see maybe what we might be able to do or who we can get you in touch with and help to guide you a little bit better, because you just find individuals bouncing around, trying everything under the sun, spending a lot of money, and going to people who either claim to have the cure or the fix, or, to be honest, don't fully understand this condition. And I get it, because people are desperate and they want help. And so that's why we offer the free consult. And you can, for those of you in the Denver area, we are on the radio every Monday. Sometimes we talk a little bit more about this topic. And we also do telehealth as well. And so this is our number. If you want to get in touch with us, please give us a call. And Lindsay can always set up a time to chat, or Ruth, even if you're just like, hey, I live in, I don't know, the Midwest, who's close to me, or what are my options there? I'm always happy to help. So I'm going to finish there. I am going to stop talking and I'm going to open it up to questions if I can get. So I'm going to go to the chat. Here we go. So I have one question. If you find a problem with the intracranial pressure with the Doppler, do you recommend a vein dilation? So great question. We don't do, like I said, we don't in our office don't do transcranial Doppler. So I won't speak too much on it because I'm just more aware of the clinical utility. But like I said, I clinically don't use it because we don't have access to it in our office, and I don't know anyone in the Denver area who does. Sometimes we will do testing to look for intracranial like hypertension. So that is a thing. So some individuals will have intracranial pressure, and that's where sometimes we'll refer out to other providers to look a little bit more at why one might have intracranial hypertension, and sometimes that is looking at MRAs or venograms or different things like that. So I hope that kind of answers your question. So yes, but I don't do a lot of that personally. I tend to, at that point, refer out to other providers. Who do you refer to for those issues? So great question. So I don't know anyone in Denver doing transcranial Dopplers. The one person I know doing a lot with transcranial Doppler is Nate Kaiser, and he is in Michigan. I want to say near like Ann Arbor, probably the main one I know pioneering using transcranial Doppler with POTS patients along with traditional autonomic testing. But in regards to some of those other things, that's where sometimes if we are seeing problems, it's determining whether we need to refer out to, vascular or medical neurology, things like that. So depending on what's going on, that's where we start sometimes going down more of the medical route. And it just depends. There's some different providers I use depending on what's going on. Are spinal adjustments a typical treatment? I have triple DD and I'm hesitant to have adjustments. Great question. So yes, so right, I am a chiropractor, so a lot of people think of just adjusting. Adjusting is a tool in the toolbox, but it is just that for me. So I like I said, being a chiropractic neurologist, I kind of try to carry myself as a kind of like a neurologist, right? I am not a medical neurologist, but in the same light where I'm really looking at the brain and trying to use as many tools in my toolbox. Do I adjust individuals with POTS? Sometimes, if I think it's necessary. So in cases where there's a whiplash injury or a neck injury that I think is contributing, we may do some things, but it is not like standard in the care of POTS or dysautonomia, if that's helpful for your question. And nor do I think it is necessary for people to get better, but in certain cases, cervical spine work or spine work can be done, but it doesn't always have to be adjustments. It can be soft tissue mobilization, things like that. But once again, it is a very small part of the toolbox. There's a lot of different things we try to use for patients. So I hope that is helpful. Can you discuss whether chronic Lyme disease can be a root cause of dysautonomia and long COVID? And do you have an opinion on treatment options like pulse antibiotics, antimicrobials, and herbs? Great question. For sure. I think any infectious disease. So yes, I think Lyme disease can be a big driver of dysautonomia. I think, and when you look at long COVID, and I think we understand, we're learning a little bit more mechanism with long COVID because there's just so much research there. But I think when you just look at, right, viral or even bacterial, just infectious disease and how it may contribute to dysautonomia, I think there's a few different thoughts. One can be like I said, the development of something like a small fiber neuropathy, which is common. The other piece is sometimes the development of secondary autoimmune conditions. The other piece is shifts to the brain's central autonomic regulation. So when we look at infectious diseases, we get increases in inflammatory molecules. So things like interleukin 6 and different inflammatory cytokines. And there is some evidence showing that that can get into the brain, right, and cross in through the brain through some different areas, the choroid plexus and some other areas within the cerebral spinal fluid. But ultimately, inflammation or immune activation in the periphery of the body can make its way into the brain, and then that will alter autonomic reflexes. And so, if you think about it, this makes sense because most of us, when we get the flu, get POTSy, right? We get POTS-like presentation, but once we have recovered, it goes away. But in some individuals, the neurological reflexes never rebooted. And this is an important concept because I think sometimes people are like, oh, I got Lyme disease. I need to treat the Lyme and I need to treat the Lyme. That's what I need to do for the dysautonomia. And maybe for some, yes, but for some others, the way I kind of analyze it is a hurricane came through, that hurricane may be Lyme disease, and it messed up a bunch of autonomic reflexes. That hurricane may be gone, but did anyone clean up the mess? And if we continue to do, things to be on the lookout for the hurricane, that's important. But if we never rebuild it's going to be hard for individuals to get better. So that's my thought on Lyme. When you look at long COVID, it's a similar idea, but on top of that, we're seeing things with hypercoagulability. We're seeing things in changes in vasculature. So I think there's honestly a lot more in COVID where the peripheral vasculature can actually be affected, changes in, once again, like fluid mechanics of blood and hypercoagulability, on top of small fiber neuropathy, on top of, I think inflammation in the brain that then can lead to dysautonomia. But I don't have a really big opinion on pulse antibiotics and antimicrobials or herbs. I don't do a lot personally to treat Lyme disease. I help to work with individuals who have neurological issues secondary to Lyme. So I work more on the rehabilitation side, but I don't treat Lyme directly. I refer out to other individuals in the area to work on that. So I kind of think of as supportive to clean up the mess that's been made by Lyme, but I don't treat Lyme directly. So I don't think I have a good answer for that. So with some of the technology that we have for our autonomic testing, we do like pulse wave velocity. So part of the technology in measuring continuous blood pressure is kind of in some of the sensors and some newer technology at looking at different waveforms of kind of rebound. So when the pulse goes and measuring the rebound flow in the artery. So there's some things where you can look at compliance with some of the technology we have. It's not the most accurate, but it's probably one of the better non-invasive ways. And so what's been really interesting is I have seen signs of peripheral artery disease in young individuals, like 30, 40-year olds after infection. Now, once again, this is not necessarily gold standard testing, but it's still pretty good testing. I've seen when individuals get better, that gets better, but that is what's been really eye-opening on that end is some of the changes to peripheral vasculature, which I think is really important, that I haven't seen as much with other infections, but, because mono is another big viral infection leading to dysautonomia, but I have not seen the vascular changes that I have seen in long COVID patients. So it does seem to be different. Well, guys, those are great questions. We got a few more minutes, so if anyone has any questions, please drop it in the chat. If not, we will wrap up for the night. Thank you so much for everyone joining and taking their evening to spend it with us. I hope that this was helpful. Share it, with an individual that you know that's struggling, and hopefully this can help get them to an appropriate provider. So thank you all so much for joining. And it doesn't look like we have any more questions. And we will wrap it up. Have a great evening. And if you guys like this info and this information, let us know. And we can do webinars on this topic, but dive deeper into other questions. So thank you so much. Have a good night.